Dr. Hu Windsor is also an alumni of University of Maryland Emergency Medicine. She completed our 6-year track in emergency medicine, internal medicine, and critical care. We've been fortunate enough to have her remain on faculty with us, where she splits her time between the emergency department and also our medical ICU. Dr. Hu Windsor is also our program director of the EM-IM program and our EM-IM critical care program. She is going to bring us up to date on recent articles we should know about in the critical care literature that are applicable to our resuscitation in the emergency department, in the acute care setting, or in the early phase of ICU care. So we're going to switch things over. Cami, if you could take it away.
All right. So. All right, do we see that okay?
We're not seeing anything yet. There you go.
All right. Well, thank you, Mike, for the kind introduction. Hello, everybody. Glad we could all come together virtually for this year's Critical Care Symposium. I don't think anyone would disagree with me if I said that so far, 2020 has been one for the books, with some ups, lots of downs, but also with some published studies that as emergency physicians, we need to know. So let's go ahead and get started. All right, my objectives today are pretty simple. We're going to talk about some studies that are pertinent to the care of our sick patients. And then hopefully we'll have somebody everybody come away with something that they didn't know before. We're going to hit the ground running. I had thought about avoiding COVID just to sort of give us all a break from it. But then this press release came out and they updated it with their paper, and I just couldn't not include it. So even though I know that there will be a discussion of COVID later, this topic had to be included today. So we're going to talk about the recovery trial. Recovery stands for Randomized Evaluation of COVID-19 Therapy, and it's still technically ongoing. It's a huge study in the UK, randomizing patients to various potential therapies and comparing them all to a single cohort of patients who are receiving usual care without experimental treatments. So Kaletra, hydroxychloroquine, azithromycin, and then today we're going to be talking about dexamethasone. So in case you haven't seen the press release, we'll talk about it a little bit here. Horby and the recovery collaborators looked at the effect of low-dose dexamethasone, so 6 milligrams, about the equivalent of prednisone 40 milligrams, in patients who were hospitalized with either diagnosed or suspected COVID-19. The enrollment of 2,000 patients was predetermined to power the study to detect a 4% mortality benefit. So they had 2,100 in the dexamethasone group and then 4,300 in that usual care cohort. Patients under 18 were allowed to be enrolled, as were, interestingly, and sort of out of the norm, pregnant and breastfeeding females, so that's interesting. And they followed these patients to whatever of the time points came first, so whether it was 28 days, hospital discharge, or death. Their primary outcome, all-cause mortality at 28 days. And then they had a variety of secondary outcomes, like need for invasive mechanical ventilation in patients who weren't previously intubated, time on the vent, need for renal replacement therapy, things that sort of make sense for this intervention. With regard to baseline characteristics, there was a random but significant age gap of 1 year in the dexamethasone group. And on average, the ventilated patients were 10 years younger than patients who didn't require any respiratory support at all. They did analyses adjusting for age that showed no difference, but just so that you're aware, these were some baseline differences, even if they didn't affect the results. The other thing was that ventilated patients were symptomatic for about a week longer than the other patients in the study, but that makes sense given what we know of how COVID infection usually progresses. So what did they find? Well, for the primary outcome, there was an increase in overall mortality at 28 days in the group who received dexamethasone. This is an absolute risk reduction of 3%. For the secondary outcomes of progression to intubation and rate of hospital discharge, there was again a benefit in the steroid group. They performed a planned stratification of the results based on a level of respiratory support that the patients required. So the groups were no support, oxygen only, and ventilated. It's important to note that the oxygen only group included high flow nasal cannula and non-invasive ventilation without a discrimination between continuous positive airway pressure or bilevel positive airway pressure. And they started oxygen in patients when the SATs were less than 95%. The ventilated group included patients who were intubated, as well as the patients who were on ECMO. And as you can see, if you look in the usual care mortality column, there's a clear difference in mortality according to disease severity. This isn't really super surprising. What you also see, if you look at the rate ratio column, is that there's a benefit of dexamethasone that increases with increasing severity. Laid out in a different format, but perhaps a little bit clearer to some, noticing that numbers on this end indicate that dexamethasone had better outcomes, and that numbers on this end indicate that usual care had better outcomes. Something falling in the middle line here, so a relative risk of 1, would indicate that there was no statistical difference. The confidence interval crossing this line here indicates that there's no statistical difference between the two groups when the patients didn't require oxygen therapy. But it does look like there's a potential trend towards harm with dexamethasone in that group. Here are the mortality curves they provide. So the red line being dexamethasone, and just sort of a graphic visualization of the improvement in mortality in patients overall, in patients who had oxygen only, and then in patients with the invasive mechanical ventilation requirement. Also sort of demonstrating that improvement with the dexamethasone is more notable with more severe illness. For secondary outcomes, median hospital duration was shorter by about a day in the dexamethasone group. There was less progression to intubation or death, and then a higher rate of discharge. For the rest of the secondary outcomes, they're still waiting to publish on those data. Some considerations that are important to note. One is that the study wasn't blinded, so we can't say for sure that the treatment teams didn't introduce any bias via the care that they gave. Also, 7% of the control group actually received some dexamethasone. So that could potentially lessen the treatment effect of dexamethasone in the intervention group. Another really important note is that all the data presented here is from a paper that is not yet peer-reviewed. They sort of just published their paper with all the data that they had, and so we still have yet to see what happens after it gets some peer review. That being said, when you look at the numbers, the number needed to treat for mortality benefit with dexamethasone is 25 for patients who require oxygen only, and 8 for ventilated patients. So that's nothing to sneeze at. 8 in ventilated patients is less than the number needed to treat for aspirin and MI. So something to just kind of keep in mind and give you perspective. So the takeaway here, I think we should be cautiously optimistic and probably should be using this low-dose dexamethasone in all of our hospitalized COVID patients who are requiring any kind of respiratory support. All right, moving on. This is the part where if we were all together in an auditorium, I would ask if anybody knows what study I'm going to be talking about next. And if you said vitamins from the comfort of your couch or your kitchen table or your bed, you would be correct. Vitamins, the vitamin C, hydrocortisone, and thiamine in patients with septic shock trial. So this combination of therapies really came to worldwide prominence in 2017 after Paul Merrick published his before and after study showing a mortality benefit. But the study had a lot of issues with methodology and selection, so really has to be taken with a grain of salt. Maybe a dash of salt, maybe a salt lick. I digress. Last year, the Citrus Ali trial saw a decrease in mortality as a secondary outcome without any benefit in the primary outcome. So it's really sort of hard to determine what benefit or what actual benefit there was and how much weight we should place on the finding. So the vitamins trial was an international trial across 3 countries, multi-center, open label, randomized. They enrolled adult patients who met the sepsis 3 criteria, all listed here. So presumed or documented infection, an increase in SOFA score, elevated lactate, and at least 2 hours of vasopressor requirement. Their intervention was the combination of vitamin C, thiamine, and hydrocortisone. And the control were patients receiving hydrocortisone. which I think was actually an important measure given the fact that we do give hydrocortisone quite frequently in our patients with septic shock. The primary outcome was time alive and free of vasopressors at day 7. So this can seem a little confusing. What this meant was that a patient had to be able to come off of pressors for at least 4 hours in order to count as free of pressors. But once they did, all the remaining time to day 7 counted, even if they restarted pressors or died afterward within the 7-day period. Patients who died before coming off pressors for 4 hours had 0 days free of pressors. Secondary outcomes, again, not unexpected for a study like this one, 28 and 90-day ICU and hospital mortality, organ support, change in SOFA score, hospital length of stay. This is a truncated baseline characteristics chart. So some comments about the study population, most were men. The average age was about 60. 60%-ish were intubated, and pulmonary and gastrointestinal infections made up the majority of the infections. Although the group was well matched in most things, there was a lower mean Apache 3 score, so less illness severity in the intervention group. There's also a higher lactate, a higher white blood cell count, and higher likelihood of milrinone use. So what did they find? Well, there was no difference in the primary outcome of hours free from pressors by day 7. With regard to the secondary outcomes, the only difference was a greater decrease in the SOFA score in the intervention group. So the SOFA score decreased by 2 points as opposed to 1 point on average. But this didn't really seem to equate to a clinically significant benefit, as there were otherwise no differences in secondary outcomes. And there were really no major adverse events reported. More consideration. So this study was also unblinded, so it's hard to say that there was no bias introduced, whether for or against the triple therapy. The median time to randomization was 12 hours, and this is important to consider. Many patients with this randomization time didn't actually receive the combo until greater than 24 hours from onset of their sepsis diagnosis. So people who, especially who are proponents of this combo therapy, have argued the potential loss of benefit was due to delay in administration. The thiamine levels weren't really checked, so we don't know if patients were actually deficient and whether or not getting thiamine was helpful. There was not really a lot of data provided on vasopressor dosing or what MAPs were achieved or targeted. And although we do know that the patients were fluid resuscitated, we don't really have information about their fluid balance or their cardiac function. So the takeaway for the vitamins trial, the combination of vitamin C, thiamine, and hydrocortisone does not demonstrate improved outcomes in septic shock compared to hydrocortisone alone. All right, so the beginning of the year gave us vitamins, and then we got the alphabet soup that is Hivictus, standing for hydrocortisone, vitamin C, and thiamine for the treatment of sepsis and septic shock. Single center, single blind, randomized, placebo-controlled, including adult patients with sepsis and a procalcitonin of greater than or equal to 2. At baseline, the treatment groups were well matched. The intervention was the triple therapy according to the Merrick protocol, and the control was normal saline. Their primary outcome was 28-day all-cause mortality. And for secondary outcomes, again, they looked at some relatively standard measures: duration of vasopressor use, ICU length of stay, organ protection / occurrence of injury, decrease in procalcitonin, etc. Now, this study was stopped early after a pre-planned interim analysis occurred when they reached half enrollment. And the reason they stopped was that when they evaluated, there was a high incidence of hypernatremia, so sodium is greater than 160, and no benefit seen in mortality. So no difference in the primary outcome. There was a trend, but it did not reach statistical significance. When they did a subgroup analysis, they found a 34% absolute risk reduction in mortality in patients who received the combo therapy if they were admitted to the ICU within 48 hours of the sepsis diagnosis. So again, proponents may say that this is a signal of benefit to earlier administration of the cocktail, which could potentially be true. The intervention group had a greater decrease in SOFA score at day 3, but otherwise there were no differences in any of the other secondary outcomes. Some thoughts. With the all-cause mortality, the confidence intervals are really wide. So if you remember that box plot before, if you fall below 1, there's, we'll say for that intervention, there's harm. If you fall for a positive study, if you fall on the line at 1, there's no difference. And then if you fall above 1, there is harm. So I said reverse that. So if we're looking at mortality, if you fall below 1, there's a benefit, right? You've decreased your risk of mortality. If you fall on 1, there's no difference. And then if you fall above 1, it demonstrates harm. So there's an increased risk of mortality. So with a range of confidence intervals from 0.4 to 1.5, you sort of span that whole range, and it's really hard to make any heads or tails of what the result is. In the end, because they stopped the study early, it's really underpowered to really detect any differences in any of the outcomes they looked at. And then the authors noted that physician teams would actually say they weren't going to give the normal saline placebo because of concerns about fluid balance. So I don't really know how blinded this study was or if that really had an effect. So the takeaway for Invictus, the study really doesn't allow us to make any conclusions. All right. So once again, if I were in the big auditorium, I would ask, what's wrong with these vital signs? And inevitably, someone would point out that the patient's hypotensive. So then I would ask, well, what is hypotension? What's our goal blood pressure? And inevitably, I would hear something like, in general, a map of less than 65 is hypotension, and a goal map is greater than 65. And then I'd ask why. Well, in general, for the past 10 to 15 years, a MAP goal of 65 has been the recommendation based on retrospective studies looking at associated outcomes with different ranges of blood pressure. But is it a must? Is it one size fits all? There have been a lot of studies looking at this, but the most recent one is the 65 trial. So the 65 trial is the short and fast way to say effect of reduced exposure to vasopressors on 90-day mortality in older critically ill patients with vasodilatory hypotension. Again, based on mostly retrospective studies, the general recommendation, including from the Surviving Sepsis campaign, is a MAP goal of greater than 65. Prior studies have looked at pushing MAPs higher to see if higher MAPs would improve outcomes, but really generally saw that they didn't improve mortality and that they were associated with a risk of harm. And in fact, the OVATION trial found that a subset of elderly patients did better in the lower MAP group. So LaMontagne, the lead investigator in OVATION, went ahead and specifically looked at the necessity of a MAP of 65 in patients older than 65. So this was a pragmatic, multi-center, randomized controlled trial, 2,400 patients in 65 ICUs across the UK. And they looked at patients who were older than 65, who had been on vasopressors for less than 6 hours, but were adequately resuscitated. They excluded shock that was not vasodilatory in nature. So they excluded hemorrhagic shock, presumed cardiogenic shock. They did exclude post-cardiopulmonary bypass vasoplegia as well. Their intervention was a targeted MAP with a range of 60 to 65 millimeters of mercury, as opposed to the control where the targeted MAP was at the treating provider's discretion, which presumably, based on guidelines, was in most instances probably greater than 65. Their primary outcome was 90-day mortality. And the secondary outcomes, again, some of the ones that we've seen, ICU and hospital mortality, days of survival, days on the ventilator, days requiring renal replacement therapy. And they also looked at functional status and quality of life at 90 days and a year. At baseline, the intervention group did have more patients who were dependent for their ADLs, but otherwise they were well matched. During the treatment and trial, there was similar fluid balance and urine output between the two groups. There was similar steroid use and inotropy use. So not very much different in terms of how they were treated otherwise. And what did they find? No difference in primary outcome. After an adjustment for pre-specified variables, which were generally comorbidities, so hypertension, CHF, etc., they did find a slight mortality benefit to the lower MAP goal. There was really no difference in any secondary outcomes. And in the lower MAP goal group, there were lower vasopressor doses required and an earlier discontinuation of vasopressors by about 5 hours on average. Surprisingly, And counterintuitively, on subgroup analysis, it was the patients with chronic hypertension, who seemed to fare best with the lower MAP goal. Although, to be fair, the study was not powered to detect a difference, but it is an interesting, perhaps, signal to note. When you look at the survival curve for this study group, you can see that the mortality benefit doesn't really seem to start until about 1 month, but then persists to 12 months. And that's keeping in mind that this was an adjusted analysis. More considerations, patients may have done slightly better in the lower MAP goal group because maintaining a blood pressure between 60 and 65 requires probably a lot more nursing attention, a lot more time in the room, a lot more time to notice other things that may need care. And then a change of 5 millimeters is a really small change. So it's likely that we're going to need more numbers in order to detect a true mortality benefit. So my takeaway for the 65 trial, in patients over 65 with vasodilatory shock, a target MAP of greater than 60, while it doesn't really have a mortality benefit, does appear to be safe. All right, last but definitely not least, we can talk about one of the great controversies in resuscitation medicine. I would ask you to raise your hands, but again, the question would be, who uses TXA for bleeding? What type of bleeding do you use it in? Does anyone use it for GI bleeds? Well, we now have another study investigating the use of TXA, and this time in GI bleeding, with the HALT-IT trial. Hemorrhage alleviation with tranexamic acid intestinal system. So the background here, we had CRASH 2, which showed us a decrease in mortality in patients with bleeding due to trauma, as long as the TXA was given before 3 hours. In the women trial, we saw no benefit in mortality, but a decrease in death due to bleeding in postpartum hemorrhage. And in the last Cochrane review in 2014, it said that it seemed like TXA was helpful, but there wasn't really good quality data. So the HALT-IT trial tried to remedy that. International, multi-center, placebo-controlled and randomized, 12,000 patients across 15 countries. In some of the included countries, the age of adulthood was 16, so the patients enrolled were 16 plus years of age, with presumed life-threatening GI bleed. The intervention was TXA given as a 1 gram loading dose over 10 minutes, followed by 3 grams infused over the next 24 hours. And the control was normal saline. Primary outcome was death due to bleeding. The rationale to the short outcome time of 5 days is that TXA is a rather short-lived medication, so the thought was that it wouldn't really likely be related to any bleeding outcomes beyond 5 days. They looked at various secondary outcomes, including rebleeding, all-cause mortality, need for procedural intervention, transfusions, and adverse events, etc. Groups were well matched, but some interesting things to point out. The upper GI bleed was the vast majority, with a high proportion of liver dysfunction and suspected variceal bleed. Also, most patients weren't demonstrating a lot in the way of shock at the time of enrollment, despite physicians noting that they felt that they were all having a potentially life-threatening bleed. And 10% of the patients were actually on anticoagulation. And just of note, the majority of these patients were also men. So what did they find? No difference in primary outcome. And then when they looked at the differences in TXA being given either before or after 3 hours, location or etiology of the bleeding, or the clinical Rockwell score, which is a validated indicator of bleeding severity and mortality risk, they still found no difference. The bad news is that there were significantly more adverse events in the TXA group. There was about an 80-ish% increase in venous thromboembolism, and then an increased rate of seizures as well, with a number needed to harm of 250 for VTE. So you can imagine if this was a widely adopted measure, it would probably cause more harm than good in a lot of patients. More considerations. So To be fair, the vast majority of patients got the TXA after 3 hours, some after 8 hours, which proponents of TXA may argue is a potential reason for no benefit, given the findings in CRASH 2. Whether this is true or not, the onset of gastrointestinal bleed is often uncertain, so especially if the patients aren't demonstrating hematemesis. So this may mean that the study is simply externally valid. And also, there was really no difference when they did look at the patients who received TXA pre 3 hours and after 3 hours. We also know that acutely ill cirrhotics have profound hypofibrinolysis, a good proportion of them, not all, but a lot. And so with 40 of the patients having underlying liver dysfunction and potential variceal bleed, it may be that they're just in a hypofibrinolytic state. And as TXA is a fibrinolysis inhibitor, it just may not be the disease process that TXA is the answer for here. So the takeaway for HALT-IT, TXA does not provide any benefit in life-threatening GI bleed and is associated with an increase in adverse events. So what are our take-home points for the day? Dexamethasone decreases mortality in patients with COVID-19 requiring respiratory support. There is no randomized controlled trial evidence that the combination of vitamin C, hydrocortisone, and thiamine improves outcomes in septic shock. In elderly patients over 65 with vasodilatory shock, a target map greater than 60 appears to be safe, but offers no mortality benefit. And TXA does not provide a benefit in GI bleed and is associated with increased venous thromboembolism and seizures. So that's it for today. There's my email and my Twitter handle. Please feel free to contact me with any questions you have, and I think we may have a little bit of time if I'm correct.
Thanks, Cami. That was great in terms of recent articles, bringing us up to speed here midway through, or as we approach midway through 2020. There are a few questions that are coming through the live stream chat feed. I'm not sure if you're able to see them, but they surround the question of vitamin C. And are you aware of any other processes that generate free radicals to which potential anti-inflammatory or vitamin therapy may be beneficial?
Wow, that is a very loaded question. I will say, honestly, that the details of that I could not spit back out at you right now. There is a lot of biologic evidence, and that's why there's such a strong pull to use it. The vitamin C is helpful, that there's some vitamin C deficiency in critical illness, and that administration of it in some in vitro and some small in vivo studies has shown decrease in leaky capillaries and things of that nature. Other biologics I can't really answer, but as far as the major details and nitty gritty, that's a lot of data to hash out today, and I can't do it.
So just to reemphasize some of the points, you've got a patient now, COVID positive patient, or strongly suspicious for COVID. The test returns during their ED course. You've got them on supplemental O2, perhaps high flow nasal cannula, or they've intubated. You think it's very reasonable to administer dexamethasone to that patient in the emergency department, correct?
I do.
Great. And then in terms of vitamin C, probably not something you're administering, whether it be in the ED or ICU for septic shock.
Yeah, not at this time.
All right. Well, our thanks again for tuning in and giving us this very informative discussion.